So today we shall be discussing about familial hypercholesterolemia. Okay, so what is familial hypercholesterolemia? It is mainly a genetic disorder of lipoprotein metabolism. Okay, so it results in an increased levels of LDL, which ultimately predisposes the person to premature cardiovascular disease. This is the main reason why we are so much concerned for this familial hypercholesterolemia, that the patient often gets a premature cardiovascular disease. The homozygous ones, they usually get it in the second decade of their life. Okay, and the nature is that it's a autosomal dominant inheritance. Okay, and there are usually the mutations are seen mainly in the three genes. So what are the three genes in which you can see the mutations in these patients? That is in your LDL receptors. There are mutations in the LDL receptors. Okay, and you can find the mutations in the ApoB, apoprotein, the main component of the atherogenic lipoproteins. Okay, so and in the PCSK9. So let me tell you briefly about this PCSK9. What is PCSK9? This is proprotein convertin subtilisin kexin type 9 protein. So this protein, this is mainly responsible. Okay, so it is mainly it attaches itself to the LDR receptors. Okay, and you know what happens when this LDL comes and attaches to the LDL receptors? This LDL along with the LDL receptors is endocytosed inside the liver cells, where this only the LDL, this is going to be metabolized, and this receptor again recycles back on the surface of the liver. But in case if this LDL receptor is attached to this PCSK9, let us draw PCSK9 with yellow. Okay, so if it's already attached with PCSK9, the problem with the LDL receptor which is attached with PCSK9 is that that particular LDL receptor will also be metabolized. Matlab, this LDL along with the LDL receptor will enter the lysosomes, and the LDL receptor will be degraded. There will be degradation of the LDL receptor. It's not going to come back again on the surface. There won't be again the recycling of the LDL receptors. So obviously, if there are less number of LDL receptors, what will happen? There will be more increased amount of LDL in the blood, because these receptors are not taking down this down regulation of the LDL receptors. So this is what is about the PCSK9. Okay, so it is found that in these patients there is excess of PCSK9. Okay, and you know this ApoB proteins, ApoB, this is actually an apolipoprotein which is present on the surface of the mainly the atherogenic lipoproteins. So if there is an excess production of ApoB, or if there is a decreased degradation of ApoB, so obviously there will be more production of atherogenic lipoproteins. Okay, so, and obviously if there is a mutation in the LDL receptor, the receptor which is mainly responsible for taking up the LDL from the blood, that will also result in excess, if there is down regulation of the LDL receptors, less number of LDL receptors present, that will also result in excess amount of LDL in the blood. So this is about it. Then we need to know that this familial cholesterolemia, this is mainly because this, as I told you just now, there is increased secretion of ApoB particles, and there is impaired LDL clearance from the blood. Okay, so the LDL is not cleared properly because of the mutations in these receptors. So it has been seen that we'll just classify this familial hypercholesterolemia into two types. That is your homozygous and the heterozygous ones. The homozygous ones are at very high risk. Let us classify it into two categories. That is your homozygous familial hypercholesterolemia, and the other one is going to be your heterozygous familial hypercholesterolemia. Remember, in the homozygous ones, in the untreated, if the patient is untreated, his cholesterol, his LDL, not cholesterol, in fact, his LDL levels that can shoot up, that can reach up to more than 465 mg per dl. And here, heterozygous ones, that is usually more than 220 mg per dl. Okay, and after treatment, in fact, after maximum tolerated drug therapy, that still remains, this is untreated. This is even after treatment, it is still above 300. Okay, and this after treatment, it reaches to around 135. Okay, so plus minus 38. right? So, and what features will you see in the patient when the patient will come to you? Will you find any cutaneous, apart from the LDL cholesterol levels, will you find just any cutaneous features? Just by looking at the patient, you can understand that, yes, he might have a history of, he might have a homozygous familial hypercholesterolemia. There are going to be tendon xanthomas. Okay, you must have all seen a tendon xanthoma. Okay, tendon xanthomas, then you can find the xanthlasma. Okay, and plantar xanthomas. So all these things are present. So in these, and yeah, one more thing is also there, you know, this around the cornea. Okay, so there is a white color, you know, a ring type is formed around the cornea, which is called as the corneal arcus. So in these patients, you can find the corneal arcus before the age of 20 years. Okay, whereas in these patients, your the heterozygous ones, here also you can find the tendon xanthomas. This thing you can find here also. You can find the xanthlasma, but in these patients, in the homozygous ones, you have got another one which I just told you, the plantar xanthomas. This usually doesn't occur in the heterozygous ones, and in the heterozygous patients, this corneal arcus, this develops usually after the age of 40 years. Okay, and these patients, they have symptomatic atherosclerosis within the second decade of life, and these have the symptomatic usually in the fourth or fifth decade of life. Okay, so remember, so this homozygous ones, they are usually at very high risk. They get the severe vascular disease at an early age, and you know, the numerous case reports of death and CABG have been reported even before the age of 10 years. Okay? And in these patients, the most common cause of death is mainly because of aortic stenosis. This is the most common and dominant cause of death in these patients, and if they are untreated, usually they die before the age of 50 years. Okay, so in these patients, we have to give the maximal medical therapy. If needed, we also go for LDL apheresis to reduce their LDL levels. Okay, so next we shall talk about the diagnosis. How are you going to diagnose? What are the different criteria for the diagnosis of this familial hypercholesterolemia? Mainly, remember, there are three clinical criteria. One which is called as your Simon-Broom criteria. Okay, another is going to be your Dutch lipid network criteria. Another is going to be a MedPed criteria. Okay, and genetic, you can go for the microarray, you can go for the sequencing. Okay, so out of all these, mainly I'm going to lay stress on this Dutch lipid network criteria, which is most commonly used. Okay, so let us talk about this Dutch lipid network criteria, Dutch lipid clinic network criteria. So in this criteria, when we calculate according to this criteria, we take certain things into consideration. First, we take the family history into consideration. Okay, we take the clinical history of the patient, we do the physical examination of the patient, and then we also look for the cholesterol levels of the patient, and we also do the DNA analysis. Okay, so these are the 5 things, okay, which we are going to do. These 5 things you need to remember: family history, clinical history, physical examinations, the cholesterol levels, and the DNA analysis. These are the things which we are going to do. So family history, I'll just write details about it. Just a minute, just clearing this slide. So in this Dutch lipid clinic network criteria, let us first look in the family history. What are you going to look at, and what are the points? How much points you are going to give? Remember, we have to calculate the total points. If the points, I tell you one by one how much points to each. If the total points, it comes to more than equal to 8 points, that means it is a definite familial hypercholesterolemia. If the points is between 6 to 7, it is a probable, and the points are between 3 to 5, then it's a possible familial hypercholesterolemia. Okay, so let us look at one by one. The family history. In the family history, remember, if a first degree relative, okay, so has got a premature coronary and vascular disease, okay, so or any first degree, okay, so if a first degree relative, they have got a premature CVD, or a first degree relative, he or she has, a known LDL above the 95th percentile. So in both these, okay, in both these cases, we give them 1 point. Okay, this is 1 point. Okay, so if the patient has got a first degree premature, first degree relative, so both of these, if it is present, we say it is 0.1. Because either or is present, it is 0.1. Then the second in the family history is that if any of the first degree relative has got tendinous xanthoma, okay, you can find the tendon, the xanthoma, tendinous xanthomas, or the patient has got a corneal arcus cornealis, it is called. Okay, so this is usually given, or in children, suppose less than 18 years, if anyone in the children who is less than 18 years in the family, if they have got a LDL more than 95th percentile, so these two, they are given 2 points. If anyone, if the patient has got tendinous xanthoma or corneal arcus, or anyone in the children in the anyone in the family has got in less than 18 years have got LDL more than 95th percentile, 2 points. Okay, next come to the clinical history. Any doubts here? You can just write down in the comments below if you're having any doubts in this this thing. Okay, so clinical history, again, if the patient himself has got a premature, premature ASCVD, that is in men before 55, in women it is before 60 years. Okay, premature coronary artery disease. So if this has happened in this patient, we give 2 points for this. Okay, and if the patient has got a premature cerebral or peripheral vascular disease, this is premature coronary vascular disease, and if the patient has got a premature cerebrovascular disease, or a peripheral vascular disease, so again, this is given your 1 point. Okay, so this is your clinical history, right? Next, let us come to the physical examination. In the physical examination, we mainly see the tendinous. See, these will carry high points. The tendinous, if the patient has got a tendinous xanthomata, this really increases the suspicion of familial hypercholesterolemia, tendinous xanthomata, or if the patient has got this arcus cornealis before the age of 45 years, prior 45 years. So both of them, they raise a high suspicion. Tendinous xanthomata, 6 points, and for this there are 4 points. Okay, and then we come to the cholesterol levels. See, cholesterol levels, there are 4, 5, there are total 4 cholesterol levels. Accordingly, we are going to arrange them. First, if the patient's LDL cholesterol levels, that is more than 8.5 millimoles per liter. Please don't get confused between millimoles per liter and mg per dl. You multiply it with 38, around 38, you get the mg per dl. Okay, so more than 8.5 is 8 points. Okay, if the LDL is between 6.5 to 8.4, don't make it 7, make it 5 points. Okay, then 6.5 to 8.4, then let us make it 5.0 to 6.4. We are going to give how much point will this carry? 3 points. Okay, and from 4.0 to 4.9, this is going to be 1 point. Okay, and last is your DNA analysis. DNA analysis is a sure shot thing. So if you find that there is a functional mutation in the LDLR gene, so how much points? This is obviously 8 points. Okay, so depending upon these points, you add up the points, whatever you're getting, and if it comes out to be more than equal to 8 points, okay, so obviously it is a definite FH. If it is between 6 to 7, it's probable, and if it is less, if it is 3 to 5 points, then it's a possible FH. And if it is less than that, then you can rule out FH. Okay, so this is your Dutch lipid clinic criteria. So just little bit I'll tell you about the MedPet criteria, although we mainly follow this Dutch lipid clinic criteria, MedPet criteria may mainly we classify them according to the age. Okay, and we calculate the total cholesterol levels in the first degree relative, second degree relative, and the third degree relative. Okay, and accordingly we classify them. right? So what are the complications? Okay, MedPed I shall discuss in another lecture. So first, let us see what are the complications of this homozygous familial hypercholesterolemia. Why we are so much concerned about this one? Because obviously there is accelerated atherosclerosis. Okay, so it is typically this atherosclerosis will be affecting the aortic root. This atherosclerosis, it affects the aortic root, and the first major cardiovascular occurs very early during adolescence. Okay, and in the patients whom they don't have LDL receptors, LDL are negative, these are the very high risk patients. Okay, and in young children they usually get the cardiovascular events in their adolescence, and they often link to aortic stenosis, and the aortic or the supravalvular aortic valve diseases may progress. Okay, so this is where this is mainly the complications. Okay, so remember, this familial hypercholesterolemia patients, they are considered as high risk. If you go through the guidelines, which is already, I've posted it in my other lectures, they all are considered under the high risk. Okay, and they are all considered as high risk according to the American College of Cardiology, American Heart Association, European Society of Cardiology, Lipid Association of India. Everywhere they are classified the high risk or very high risk. Okay, and in these patients, remember, your ultimate goal, if they are having familial hypercholesterolemia plus some other risk factor, then you try to lower it down. Okay, so according to the ESC, European Society of Cardiology, if the patient has got familial hypercholesterolemia plus some other risk factor also, you lower it down to 55 according to the other criteria, and according to the European Society of Cardiology. Yes, the familial hypercholesterolemia patients, we lower it to less than 55. And if they have no other risk factors, only they have familial hypercholesterolemia, that also it is considered as high risk. And we usually try to lower it down to less than 70. Okay, so less than 70 and 50% reduction in the baseline and 50% reduction in the baseline levels. Okay, so these are the goals which have been set for these familial hypercholesterolemia patients according to the ESC guidelines. Okay, so in combination, you can also go for the lipoprotein apheresis if is often needed in these patients. And if you do the proper therapy in these patients, if you can achieve these goals, then the risk of CHD that can be decreased by nearly 80%. Okay, so what are the current treatment options for these patients? Obviously, the conventional treatments, you start them with statins, not able to achieve their goals, go for ezetimibe, and still not able to achieve their goal. You have these new molecules, that is your lomitapide, mipomersen. But these two molecules, they carry a risk of hepatotoxicity. So instead of these, you can also use the PCSK9 inhibitors. They are also very potent in lowering the cholesterol. And if still nothing works, you can go for the LDL apheresis. In this PCSK9 inhibitors, you have got drugs like evolocumab, you have got drugs like alirocumab. Okay, so this is all about the treatment. So always remember, whenever you start with monotherapy, then you go for 2-drug therapy. If still not able to attain, then you go for a 3-drug combination. Then you can go for complex therapies. You can consider 4-drug combination plus the LDL apheresis. Usually you start with high intensity statin, rosuva or atorvastatin. Okay, and then you add ezetimibe. Still the goal, usually just after the guidelines I'm telling you, usually after adding statins, we wait for 3 months, and even after 3 months, LDL is still above the goal, we go for ezetimibe. After adding ezetimibe, still after 3 months, again the patient is the LDL goals are still not achieved, we go for some alternate therapy. Usually we go for the PCSK9 inhibitors, and then again after 3 months still there is no benefit, we can go for the 4-drug combinations. In the 4-drug combinations, we can add, along with these, we can add niacin, or we can add the colazevelam. Still not able to achieve, then we can go for the LDL apheresis. So this is your treatment guidelines. This was your conventional treatment, and the novel treatment guidelines, as I told you, this lomitapide, mipomycin, and this PCSK9 inhibitors, milivolocumab, alirocumab, bososicumab. Okay, so these are the new molecules which have come, and they produce a quite good lowering of the LDL cholesterol. Nearly they produce 50% extra. On top of the statins, there is more 50% reduction in the LDL cholesterol. Okay, so this is all about your familial hypercholesterolemia in short.